Good afternoon. So in this particular session, we'll be discussing about the communication in the ICU setting, and which is kind of slightly different from what we experience in the OPD or the ward setting. And in this panel, I'll just introduce the panelists. We have with us Dr. Yatin Mehta, who is spearheading the critical care services at Medanta Medicity. We have Dr. Kaushal Madan, who is the senior gastroenterologist and hepatologist at Max Saket. And we have Dr. Bansal, who is spearheading the nephrology department at Medanta Medicity. I'm Dr. Khalid. I'm an endocrinologist, so not really into critical care, but do get involved with the multidisciplinary team meeting. So some knowledge. And Dr. Nikhil Aggarwal, who is a physician. So to begin with, I'll just, we had a lot of discussion about how we communicate with the patients. And so slight difference in what happens in the ICU setting is that the patient is not in a position to take the decision himself or herself. So either because of he or she is very ill, or he's on ventilator or deeply sedated, where such certain decisions have to be made by a proxy, and that can be family members. So our communication strategies obviously will be different. And also, like in a routine OPD and ward setting where family members or the patient are involved in the decision making, the same thing doesn't happen. Obviously, there is some difference in the level of access which the attendants or the patient have with the caregiver. So that is also one of the factors. So to just begin with how I approach, I'll give 3 scenarios. So patient comes to the emergency of the hospital in a very sick state, and he gets directly admitted to the critical care ward. Then there are patients who come for surgery, routine surgeries, complicated surgeries, where there is a defined limit where in the post-op state, the patient will be in the critical care ward, surgical ICU, for instance. So for example, patients with undergoing CABG, we know that for 24 to 48 hours, they will be in the ICU, and afterwards they will be shifted to ward. And then there is third scenario where patient comes with certain disease for which ward care has been provided. And because of certain problems, the patient deteriorates, and there is a code orange or a rapid response code, because of which the patient gets shifted to ICU. So this is 3 different scenarios. And how do we approach these patients, and how do we discuss the problems related to these patients with the family members? Because obviously, in terms of prognosis, all these things will be different. So, Dr. Yatin.
See, all the 3 scenarios are a little different. If you look at it, after a routine or major elective surgery, patient would stay for a couple of days in the ICU. The patient's family have already been told about it, and hopefully the patient should be stable. So there's no issue there. You just need to inform what surgery was done and if the patient is stable, not stable. If that sort of a patient has certain complications, where again the organs fail, where patient needs some support, you do not know how long it is going to take. It may take days to get better or worse, and the outcome you're really not sure about. That is where the problems also begin. I mean, that you need to. I face these sort of problems every day. In this sort of scenario, I think best is to be honest and straight with the patient. I think do not try to hide things. Every surgery can have certain complications, expected or unexpected. Every human body reacts differently. They should realize that. I mean, and they should be told if there is anything. If the patient is bled and you just tell them that there is a possibility of bleeding and this is what can happen. If the family thinks that you are talking to them straight and honestly, then they react quite okay. Even the patient does not improve, they will take it. Then the cost factor comes in at later stage. Second sort of patients, which you said, which is the first category, which come from to the ICU straight. And by and large, they are sick patients. Either they are coming from another hospital, another ICU, or they come with polytrauma or high blood pressure being low in the in the emergency room, or drug overdosage, or whatever. So they are sick patients. Again, I think you should, in the emergency room itself, it's better to be straight again with the patient. You tell them that this is the situation and what is the prognosis, what is the outcome likely to be, and how long it will likely to get better or worse. Cost also should be discussed at that point of time before the patient gets admitted, because that is one of the private hospitals, that is one of the major reasons of grief of everybody, and anger and hostility. I mean, if they know what this is going to cost, otherwise, if suppose they say they cannot afford it, then we try to help them in adjusting them in some government hospital. We talk to some doctors who are known to you and try to accommodate them, stabilize and accommodate them there, rather than trying to, I mean, face the fireworks later on when they cannot meet the bills. Because as doctors, most of us have very little control over the billing of the hospital. That is done by different administrative. They say. So, I mean, even if the doctor does not charge his fee to visiting, how much it is a drop in the ocean according to what the ICU care of cost is. And third group of patients which you talked about are medical patients who are okay in the floor, in the ward, regular ward, and then the condition suddenly deteriorates because of code orange, as you rightly said it. Now, these are also unexpected deterioration. So obviously the intensive care doctor as well as the primary physician, both should be on the same page, and both should sit down with the family, at least on the day of transferring to the intensive care unit or any change in major condition, and explain to the family and obviously document all that. But main thing in all this thing is you should be straight with the patients. That is honest. Don't try to hide anything with the patient. And you should be sympathetic, empathetic. They should realize that you care for them and you are doing your best. Even if the patient does not make it, I have seen hundreds of patients like that, families who have died in my ICU. I've got 30, 40 years of practice in the ICU. But if they, most of the times, if they think that you have done your best, still, despite that the patients did not survive, they'll be all right with you. And some of them have made friends for life, even after the patient has died. But they should realize that you are doing your best, and they should get that feeling. It's like what we talk in law, that justice should be done and justice should be seen to be done. So that is what is important.
See, one of the complaints sometimes I hear from the patients, from patient perspective, the patient in the ICU, he's admitted under some other specialty, nephrology or gastro or whatever, and because of the certain situation, he's now shifted to ICU. And sometimes the patient complained that there is a different information they are getting from the different doctors, and there is a big communication gap. Sometimes patients feel there are different things are being informed, and there's a lack of coordination among the various teams, and they don't know that how to, and that happens with our setting. So that is means one of the, I think, area. There are two important one you mentioned is obviously the cost. As long the hospital stay, especially the ICU stays goes, the cost goes very high, and the family is not prepared. You also don't know sometimes whether the cost is because you did not anticipate this complication particularly will happen in this patient. And then secondly, then because the cost goes up, and if there is a communication gap, so how do you feel that can be sorted out, or what should be done to avoid these types of problems?
I think that is one of the most important issues which you raised, that if there is a discordant opinion between the primary physician and the ICU physician, that causes a lot of mistrust and grief among the patient. So I think the primary physician and the intensive care doctor both should sit down together before they talk to the family. And every day they may not meet, they may not have the time. We all are busy doctors to meet at the same time. But every day they should have a discussion about that patient, that this is what is to be done for the patient. That is a plan of action for treatment and also plan of communication.
I think, Doctor, maybe so. I think one important part which I feel I'll ask Dr. Kaushal also, that that probably the counseling, the different counseling by the different team, rather than you go see a patient in ICU, talk to the ICU doctor, and then tell ICU doctor, or ICU doctor tells you what he's going to convey to the relatives, because sometimes combined meetings might not be possible always, because there are different timing of the grounds and all that. So maybe the ICU doctor knows what you are going to tell, and you know what the ICU doctor is going to tell, or maybe it's a combined counseling. That, what do you think, doctor?
I agree. I think the best way to do that is when you are going for your rounds, it's best that the intensivist and the treating physician takes the round together. Even if it even if it means a junior consultant or a junior doctor from the intensivist team joins the round which you are taking, then you are know on what page they are. They know what you are thinking, and then when you go out and counsel the patient, then both are coming out with a common theme or a common plan. And second, you're right. In difficult patients, you have to have multidisciplinary team meeting where 3 or 4 doctors together have a meeting. But that is frequency cannot be daily. So that, but trouble patients, difficult patients, especially patients who've had complications, especially patients like these who have crashed in the ward and then gone there and have multi-system involvement. It's always important to have multidisciplinary team meeting. The patient family also feels that the because the administrator also is there during those meetings. So the administrator also is aware of what the family must be thinking about the costs, as well as the fear in their mind that something wrong had happened in the hospital. So all those are covered in that multidisciplinary team meeting where an administrator is also there.
Yeah, Dr. Nikhil, what is your perspective? Dr. Nikhil is a physician. He is also a cancer survivor. And from both point of view, from the patient point of view, as a physician point of view, what do you think in ICUs?
Okay. Yeah, as you told me, I'm a general physician and 2-time blood cancer survivor. And I have met a lot of doctors as a patient, general physician, hematologist, other cancer department. And I had a liver issue. I met Dr. Kaushal also. I mean, it was 10 years back in Medanta. And then my other part of treatment was at CMC Vellore. And after that also, I have had issues with my eyes, my hips and lungs. And I have been to a lot of doctors in different settings. And the thing which we are discussing right now, I saw in CMC Vellore, they have a very nice thing. After rounds daily, the whole team, right from the HOD to the junior most resident, they have a meeting daily morning, roughly around 9 o'clock, and they discuss each and every patient, even the patient from the other units. And in that meeting, they also have their pathologist and microbiologist. So a lot of things come up, and the whole team is aware of every patient, and the decision making is much better, and the patient care is much better. Even their nurses, the senior most nurses, they also follow the same protocol right from the top. So the discrepancy which we see a lot of time as a patient between different departments, different doctors, like sir was saying right now, okay, the ICU doctor will say something, the physician will say something. That thing is not at all there. And the junior doctors, they are very strict about this thing. They will say only what they know to be correct. They won't, I mean, sometimes it feels a patient is not having enough communication, but they won't say something which would contradict what anybody else would have said. That is one thing. And another thing about communication which I want to say is we were discussing the other day, there's a lot big issue about uh, assuming doctor as a god or someone with the superpowers. So now as we discuss about humanizing medicine, so the doctor as well as the patient, both are human. It is not only we have to discuss about the patient or about the doctor. So both have their shortcomings, their emotions. And I have seen my doctors, like when I was sick or when other patients were sick, the doctors were very feeling very low. They were also emotionally attached to the patients, which many patients don't see unless they are in that scenario. But general public, they think doctors are only for prescribing investigations and making up bills. but that is definitely not there. And I would say that the communication has to be very good between the patient and the doctor, and of course with the family also. But the doctor patient direct relation, that is something which helps a lot. As Dr. Yatin said, if the patient and the family understand that you have done whatever best you could have done, then they are much more comfortable in accepting even the bad outcomes.
So one thing, sir, this is we are discussing about shared decision makings in ICU because the most of the time patient is sick, so he is not involved in the decision making. It's just family member and the treating physician and the critical care. They are involved in the decision making. So means sometimes there are difficult areas like you want to put a patient on ventilator, or you want to put a patient on dialysis, or maybe some treatment for liver disease, or so how means how often do you find that patient they and patient is able to, your family is able to understand the point of view of the doctor or the physician, or there is a lot of actually distrust or lot of disbelief, oh, what is this, and this was not to be, and how this happened, and this can't happen, and what do you think is the key to make it better, and how do you take this?
See, many times as physicians in charge of those patients whose lives are dependent on many times artificial machines to continue. I think it becomes important for us not to be the physician, not only to be the physician, but also to guide the patients. You can sort of nudge them towards what direction you think they should go. I do it all the time. At least I must be doing it once a day to some family where the father is 85 years old, he's got a malignancy everywhere, the body, and he needs to be put on ideally, medically speaking, he needs to be put on a ventilator. But does he really need to? You're not prolonging life, you're going to have a worse quality of life, even if he survives that particular pneumonia episode with the tracheostomy and all that. What was the quality of the patient's life before? That is important, before he came to the intensive care unit, so that I always take into consideration. And many times, if I think not much should be done, patient should be made comfortable, painless, warm, and sometimes I give them extra passes to sit with the family with a longer period of time because they would like it, and that I allow them. But many times I tell them about my own story, and that works many times. My father, many years back, I was at Apollo Hospital before Medanta started. For 2 years, our team was there. And my father had a pneumonia. He was 93 years old. He had been in bed for 2 years. So pneumonia is a treatable disease. We started antibiotics. He was admitted under me in my own ICU. And when the time came, he was not getting any better. The question came whether to put him on a ventilator or not. And I discussed with my two brothers, because in such scenario, it is important that at least the direct descendants or wife are on the same page. If there is any discrepancy, I think the doctor should not try to get into that, because then there can be features. They all should be on the same page. My two brothers left it to me. And I said, we will not put him on a ventilator. So I managed him with a non-invasive ventilator, with oxygen from outside, antibiotics, intravenous fluids, made him comfortable. It took 3-4 days. My every family member came and sat with him for a while, and he died peacefully. And we all felt good about his going, because he had a full life. So celebrate his life rather than his death, and ultimately everybody has to die. That should be, I mean, they understand that. But most of the times they do understand. Because if this is what I say, if it was my father or mother, I would not go beyond this. But obviously, you cannot withdraw the treatment in India. That is legally still not valid. So I would advise not to tread on that thin ice. But at least this much you can do, not to be too aggressive and prolong their misery.
Yeah, so since we're all talking about communication, it's also important the place where you communicate. And I must congratulate Dr. Yatin, because he was part of building that process in Medanta. And the best part when I joined Medanta was this: when we used to see patients outside each ICU, they have a separate room called the counseling room, and it helps you a lot. it gives you a privacy. The entire patient family, 4 or 5 or 6 people sit on the other side, 2 or 3 doctors sit on this side, explain all the processes, spend time with the patient. If the patient has to get emotional, it's in the privacy of that room. If the patient has to complain about the doctor, what is going inside, it's in the privacy of the room. All other places, you come out of the ICU, there are 10 family members standing, and you do counseling there. So I think it's very important to have a separate counseling room outside the ICU where you spend time, maybe at least 5 minutes for each patient, explaining all the pros and cons. You can also be very truthful in that private room. You can tell the family members exactly what is wrong. You can accept your problems, accept your limitations also. So that place is very important. I think all ICU should have a counseling room outside, and it should be a practice. Maybe you can get it into JCI or NABH that all ICU patients have to be counseled once in a day in a private room where you may have a video recording also if you want.
So one particular scenario is that if there are multiple family members, multiple stakeholders involved, and they have a difference of opinion in the kind of approach. For instance, like you mentioned that you took the palliative route, did not go forward with the invasive route. So in such a situation, say for two different family members have two different opinions regarding the line of treatment. So how would you approach that scenario? Because obviously we would not be siding with any particular family member, because that would be wrong. So how do you approach, because we would be seeing so many such cases?
See, India is a very family-oriented society. Tauji, Chachaji, Bhanja, Bhatija, everybody will come in the decision making of what's to be done to the patient. First of all, don't get into that. If there are 3 sons, I would take the opinion of all the 3 sons. Daughter-in-laws and all can sit and listen, but everybody you cannot. It's not a panchayat running. I mean, it's the patient care and who's terribly sick. So as I said, right, all the direct relatives, that means wife and children, should be on the same page. If you have to take a decision whether to put him on ventilator or dialyze him or do more aggressive therapy, so they all should be on the same page. So you explain the patient's condition to the family together. Many of them say, "Arey, aapne mere chote bhai ko bataya, bade ab mujhe nahi pata, mujhe bataya." I cannot do that because none of us, we are busy doctors, we don't have that sort of time. So I tell them, once a day, I or somebody senior from my team will explain it to you, but I cannot do it every 2 hours or every twice a day or whatever. So they all have to be on the same page. Otherwise, don't tread that path. Then be aggressive and you have to treat the patient because medico-legally that's what needs to be done. Do not escalate or do not intervene also has really very thin gray zone in Indian legal parlance. So don't get into that.
So do we have DNR?
No, we do not. See, DNR, so there is DNR, but they made it so complicated. It is impossible. See, you have to have a hospital committee of 2, 3, 4 doctors who will look at the patient and make a report. You have to submit it to the district magistrate, and the district magistrate will give a permission. And now who has either the time or who wants to go that way? I mean, it should be much simpler. I used to work in UK and Europe for many years, and it is so much easier there. The family, you just talk to the family and you tell them that I won't go ahead, and they say, "Sir, fine, doctor, just don't do anything more. Just make him comfortable and painless." But that's not true. No, as I said, we have DNR, but government should modify the law to make it simpler. It should be obviously transparent. There should be no misuse. But it should be easier for doctors to practice.
No, sir, that's very difficult even for the patients. For example, a patient comes in today morning and you know that possibly he'll not make it through the night. Right now, he's not intubated. So the family says, if I go back home in the night, patient is in ICU, and somebody would intubate that patient and start resuscitating. I don't want that. So you won't get that permission from the magistrate on the same day. So how do you do that?
See, none of us go that way, actually. Anyway, to be honest, none of us goes through the magistrate and thing. If there is one patient's relative who is supposed to be directly responsible for that patient in the ICU, because obviously he's sick enough to be in the ICU and mostly is not fit enough to give a consent or whatever. So There is one person who's authorized for that patient on his behalf. So we'll have to take that. What we do is we take the negative consent from that patient. But as I said, that this is not foolproof. But again, see, from the humanizing point of view and from the being sensitive to the patient's requirements, if the son does not want the father to be tortured further, and you say that legally I'm not this thing and I will do it, that's not right. That patient is going to mostly die, as you rightly said. And is it fair? But you have to protect yourself also. So it's a very difficult line to walk on.
So there are two important things we sometimes come across in ICU. One is the bad outcome. So somebody came maybe in bad shape or initially not so in bad shape. He deteriorated further. You are explaining to the family on daily basis that he is probably not going to make it, but family is not ready to accept it. They say maybe he is a young person and whatever complication he had, delayed treatment or whatever, you now can't blame them for that or what that many happens in kidney patients start late and then they are so one thing is that what you do with that patient, and secondly, do you think I find sometime that as a patient or as a family member there the doctor also that there should be something like accepting the thing or maybe some philosophy that ultimately everyone is not, if it's an elderly person or something elderly, everyone is going to die and we have to accept that in a good manner and we did whatever we did. So means do you come across such scenario and do you feel that because the doctor or the team is trying hard to tell but they are not taking it?
It again happens all the time that you try to explain it to them and they do not either want to understand or do not understand despite your best efforts. And they will want everything to be done. And I may sound insensitive here. We are all not all doctors. Some of you are other professions, but many times when somebody else is paying the bill, then they would want everything to be done forever because it is not hurting them financially. There's a completely different attitude of most of the family when you are paying the bill or some agency is paying the bill. Unfortunately. I do try to explain it to many of them that there is no real point, but this thing, but they do not understand. And you have to, in that case, you just go ahead and do everything, whatever needs to be done medically or legally correct.
In that context, I just want to ask a question. So, like what Dr. Kausal is saying about video recording, because most of the times, because it is very good streamlined in Medanta, so we have counseling room, we do counsel in our local language, and then we write down on the notes to get signed. So those notes are in English, and we are counseling in the Hindi. So sometimes after the patient can come out and say, I am not understood what you have said in the court of law. So it needs to be in their language, and you can't have two languages writing every time from the patient. So video recording should be how legal it is, because the empathy that the doctor shows to the patient doesn't come out in the paper. It comes in the video, how you are talking, how you are explaining them. So should it be a regular term for all the ICUs to have a video recording about the counseling part?
See, video recording is a two-edged sword. It will cut both ways. So under circumstances, it may be a good idea to have, like for liver transplant or for a kidney transplant, it may be a good idea because medical legally, again, there can be issues later on. But every day, if you do every counseling with video recording, it is going to be a touchy issue. Because I have taken 3 minutes to talk to you. Because I've got 25 patients waiting, family waiting. It can be said in the court, oh, he gave me only 3 minutes, my father was dying. He should have sat with me for half an hour. Or look at his face, he was not looking sensitive. Or look at him, he was answering another phone call. Now, I'm not chatting with my wife. I may have got a phone call from another patient or another ICU. But that the judge does not know that. So I think that is a difficult situation. But what we do is, except for the liver transplant where it is video recorded, at our place we have a counseling form which signed by the doctor and by the family who's there. in the language it says, in the language which he understands. I always ask, "Aap Hindi, English, kisme Punjabi, kisme aap comfortable hai?" And they sign that. Then at least you have some this thing that you have explained it to them, what is the prognosis and what is not. But video recording can cut both ways.
So in the last 2 years, obviously, because of the COVID, our practices have changed a lot. And one thing that we all have experienced is again decision making in times of COVID, especially in critical patients. Now, again, the same process which we are following previously would not be kind of applicable because face-to-face meetings was not possible. In such a scenario, when decisions like intubation or escalation of treatment is needed, or starting something like a dialysis. So how would you, how has been your approach in these last 2 years?
Very difficult situation because the same thing. You are going to do an invasive procedure in the patient, you require a consent, but family is not there because they are not supposed to come there. So we take a verbal consent. And one of the witnesses signs. That's how it happens. A couple of guys have sued me. This was never told to me, but fortunately the documentation was all right. But it's a difficult sort of situation because again, legally you can be on thin ice. But what to do? I mean, those people are not supposed to come to the COVID ward. And how do you take a consent? And how do you do a procedure without consent? You can't do that. So we take a verbal consent and we write the name and time when it is done. Most of the time it works.
Dr. Kaushal, your experience in the last 2 years, especially we have all faced critical patients, liver disease, decompensating, having COVID, and then again getting into complications. So how have you dealt with it?
So I think one, I don't know, fortunate or unfortunate, we were not required to go and see patients in the COVID ICUs. But what we experienced was that our patients who were admitted with liver failure or complicated GI issues requiring ICU and then detected to have COVID and then were shifted to COVID ICU where we had no control. It was very difficult to manage, and the communications definitely were very, very bad during that time. So it was a three-way communication. The COVID ICU, first we will get in touch with the guy who was working in the COVID ICU, get that information out, or whatever was there in the HIS, take that information and then give it to the relatives. So you had to communicate them about what was happening to COVID, what was happening to their basic disease. And I'm sure a lot of patients, I think it was very difficult. They would have been harmed because of this lack of communication, I think.
See, what the COVIDs were very difficult times because patients were sick in the intensive care unit. Many of them would die. They are alone. They cannot see their family. The family cannot see them. They cannot see the doctor because the doctor is in a space suit, so they can't even recognize his face. So when I go in, I always put my name on the, there's a nameplate sort of thing on my, this thing, this nurse puts it on a piece of paper. They know at least this is Dr. Mehta who is talking to us. Many times what I do is on a video. We have the technology now, that at least on a WhatsApp or on with a laptop, you can make them talk to the family. They feel better, particularly if they're dying. If they're very sick, then I make them see the relative at least once a day. And very occasionally, I have made an exception that somebody, daughter has come from US, she is a doctor, the father is dying, she's never going to see the father again. So I do make them put on the full spacesuit and go inside and be with the parent for a little while. But I can't do it for every patient. At one point of time, we had 120 patients in the intensive care unit. If I start doing it for everybody, I mean, Haryana would run out of spacesuits. So, I mean, exceptional cases, I look at how the patients, if they're very emotional or the patient is dying, I would make an exception and let them go inside.
So since you brought this issue up, I think you've been at the front line since you were ICU in charge during COVID ICUs. So I think this concept of ICU psychosis, I think it would have been exaggerated 10 to 20 times because of the COVID per se. Normally in ICU say that if you don't have a window bed and you're not seeing daylight, you have ICU psychosis. And there were 10 more reasons to have ICU psychosis. They are not seeing your relatives, not seeing the doctor, not seeing the face of the doctor, nurses not visiting them more frequently like they used to visit a normal patient. So how did you manage that? The stories we have heard from our relatives, our friends who were in COVID ICUs were very scary. I mean, there were reports of, patients saying that, I'm talking about the patient perspective, that we were left alone. We would rather die at home than be in the COVID ICU. So what do you have to say about that? I am not blaming anyone, but since we are discussing this, I think.
No, no, they were very difficult times from the same point of view. At one point of time in one ICU, I had three brothers who were admitted in my ICU. Each was sicker than the other. Each was dying. And each brother would ask about the other brothers. He would not ask how I am doing, but how my two brothers are doing. Then I had my father in one ICU, mother was next ICU, and the son was in the other ICU. Son got better because younger. And he wanted to meet his parents before he went. And I allowed that. So he met the mother, he met the father in the other ICU, went to the ward, and father died, and mother fortunately survived. But there are lots of stories like that. The family has been finished without. See, this is the worst time for anybody to die, COVID. Because when you are sick in the ICU, your family cannot see you. You cannot see even the doctor whom is treating you. When you die, again, the family cannot be with you. You are taken in a place where only few relatives are allowed. So it's a miserable time period for all of us. Misery in death and misery in dying. This was bad times. They couldn't do it at that point of time. As I said, I am also making some exceptions now because we don't have many patients. But again, see, there is not only a question of logistics. It requires somebody to help you putting on the ground clothes and things. Somebody to help you take it out. Somebody to direct you to the shower because we are supposed to have a shower and change our clothes. Now, how do I have that sort of stuff?
Now it's not needed anymore.
No, see, again, let me say, from I think Dr. Guleria has said that it is not required PPE, but I completely disagree with it.
Sir, in the ICU, the PPE is required, definitely, but outside,
It's difficult to say. See, whether the patient is infected for 7 days, statistically, yes. Is it for 10 days? I don't know. You cannot definitely say that at 7 days he becomes non-infective and then he becomes
but
okay.
isn't a mask enough?
So-
Because we are seeing patients outpatient day in, day out. They are not the ICU level, so of course the rate of transmission is higher in the ICU as opposed to outpatient patients are much have a maybe a lesser viral load, or the rate of transmission is less. And of course, you're doing whenever you have to ventilate or whenever you have to take care of the patient's fluids, etc., would be an issue. So definitely, PPE would be required in the ICU, but outpatient maybe not required. Number
No,
one.
outpatient is not certainly not required.
So
An
when the
outpatient
relative comes in, would they need help to remove it and go and have a shower?
in the ICU, yes.
In the ICU still? That's what I'm asking.
In the ICU, yes.
See, the time we were discussing, like last Delta wave we were discussing, that time situation were very different.
That was
This time situation is totally different. There are very few patients. There's no means mortality is also not so much younger patient. Previously, the things were, I think, totally at that time nobody could have allowed or done anything which is not according to the guidelines. Or this time things are different. Now
That
the
time
countries
awareness
have
was
even
also not there
allowed
about
that you can do without, even some countries are allowed no isolation or no this thing is
So
required.
as it progresses, we learn, we course
Yeah,
correct.
so we
So-
previous things were different. We are all talking about the
So,
Delta
yeah,
wave.
so-
Okay, as a patient, I want to add 2-3 things about what all we have discussed. One is I had a stem cell transplant. That time I was in an isolation room for 15 days, and that was an like ICU only. So as a patient, I was of course concerned about myself, but I had a great trust in my doctors, in the whole team. But that time I was much concerned about my relatives, my parents also. So that aspect also need to be addressed, because when a patient is in the ICU, be it like if it's an elderly patient, they are concerned about, because they assume that we might not survive this. So they are much concerned about their dependents. And as I was a young person, so I was concerned that how will my parents take it? And I knew in my mind, okay, they are supposedly crying daily. They are all sitting together and crying. But that part I accepted because that can't change when I was in that situation. But how they are being addressed by the doctors, by the teams, how much they are aware about my condition, that was going on my mind. Because as such, yes, I had lots of complications, lots of things, but still I was comfortable, I would say. But my concern was more about them. That is one thing. And second thing is, uh, during my treatment after the relapse, I had to be in ICU for one night. I had bad pneumonia. So that time, what I feel is that my treating doctor, he had to go abroad for 2 3 days, and when he went, second day I got worse, and I had to be shifted to the ICU. And he also wanted me in ICU because he was not there personally to take care of me. So what happened is that they shifted me to a isolation room again in the ICU, but my experience was very bad because firstly I was comfortable and in trust with my treating doctor who was not there. In ICU it was a totally different team, even the nurses, because my stay was quite long, like I was in ward for 10 days around. So I had developed a good synchronology with my nurses and every staff. But suddenly everything changed, and it was isolation room, so my parents were also not there, I was alone. And a small incident happened that they started me on amphotericin, and suddenly I started having reaction to that. And that time, what happened is that the nurse went out. She started me on the drip, and she went out because uh, she was so much overburdened with paperwork. I mean, she was able to take care of me less and more of the paperwork. So I felt that things should change. And that time she went out and I had reaction. But being a doctor, I could sense that I just immediately stopped the drip myself. But if it would have been other patient, the things could have been bad. And after that also, of course, the doctors and everybody came and they gave me hydrocod and everything. So after that, again, they wanted to start back the drip, but I was not ready. So I was adamant, okay, no, I can't take that chance again, even if you all are here. So those kinds of things are there, and sometimes they are uh, out of our control, because my doctor, if he would have been there, he would have come definitely, but he was not there. So as Dr. Yatin said, the counseling when the patient is shifted from ward to ICU, that should be done very well, and the main doctor, the family, and the ICU doctor, they all should be in that conversation. And lastly, the thing is, uh, when we are talking about stopping the treatment, when we understand the outcomes may not be good in critically ill patients, so that time we discussed yesterday also, there is one social aspect also, ये लोग क्या कहेंगे. So the thing is, as you said about financial thing, if they know somebody is paying, they are ready to take more intensive, more aggressive treatment. But if it has to be from their pocket, they are reserved. So another thing is that socially, the children or the parents or anybody, they have a social pressure. How can you stop the treatment? So it might have been that the patient would have recovered or not. But even if they know that the chances are slim, they have a social pressure. Like during this COVID time, one of my cousin, 32 years age only, he had very bad pneumonia, very bad. And in our mind, everybody knew that he can't be saved. But again, uh, people were talking to me being a doctor. So they were like, yes, we understand the chances are very slim, but how can we stop it? And they went for ECMO and everything, and they spent huge money and they couldn't afford. They borrowed it from relatives, and still he didn't survive. So in their mind, they knew it is beyond our control now, but they couldn't stop getting whatever is possible. So I mean, lots and lots of complications. I haven't been in ICU as a doctor, but I can imagine how tough it is for you people to manage and to counsel. And another thing is, it is not only about the patient. As a doctor, when you are in connected with a patient for even for 5 days, 10 days, you develop a lot of emotions with them. I mean, you can try to keep that part separate, but it is again, as a human, we get that. So when things
Thank you,
go
Dr.
out of
Nikhil,
it,
for
yeah.
you make your points. So I think we finished this channel.
And I think what made the last point is very relevant. We are discussing like very practical things, but there are times when I am sure, I mean, we are doing all this while every day we are absorbing so much there. It's a difficult task, managing communication in critical care. Thank you very much, all of you, and I'm sure a lot of messages will go across from this discussion.